Good afternoon, everyone. Welcome to the Tech Titans Health Tech Forum presentation on virtual healthcare and where it's headed in the current and post-COVID-19 environment. I'm Bob Kaiser. I'm a clinical professor and a program director for our Healthcare Leadership and Management graduate program at UT Dallas. I'm also a member of the Health Tech Forum Committee at Tech Titans. And I'm delighted to be with you today and serve as the moderator for today's program. But before we begin, there are a few announcements. They're intended to make the program run smoothly and efficiently. Well, as you know, we're using Zoom platform today, and you get the best presentation by selecting active speaker view instead of the gallery view. When you're in the gallery view, you get to see everybody. And the active speaker, you'll see the active speaker, which at times will be me, at times will be our guest, Dr. Pardeep Shori as well. So anyhow, kind of move to that direction if you can. With Zoom, you have a lot of capabilities, a lot of features, and we have a host who can control you and mute you and make you go off the screen if you misbehave. So you're all familiar with Zoom and how it works. You'll be able to post your questions real easily using the chat feature that's located at the bottom of your screen. And what we'll do, we'll try to capture all the questions and verbally engage with answers as we take each of the questions here at the end of the session. So that should work out pretty well. The Health Tech Forum, it brings together professionals in all stages of health technology development, commercialization, and use in North Texas through the programs that focus on best practices and exchange of information and identification of solutions. The Health Tech Forum, this is part of Tech Titans. And if you're not familiar with Tech Titans, it's the largest technology trade association in Texas with about 375 member companies and numerous individuals. And Tech Titans, you know, we plan to be champions and serve the technology community across North Texas. So if you're interested in joining, yes, you can contact Barbara Tunstall via email. And that's easy. You just send an email to Barbara@techtitans.org. That is Barbara@techtitans.org. She's also online here today, so if you want to private message her, you can say, I want to join as well. But Tech Titans, it has several really good virtual programs coming up later this week and next week too. You don't want to miss this Friday's virtual presentation on the Tech Industry Luncheon. We'll have the CEO of AT&T's business division, Ann Chow. She'll be talking about AT&T's response to COVID-19 and the future of technology, and specifically 5G. You can register for this event or check out some of the other upcoming Tech Titans programs at our website, techtitans.org. Easy to find, techtitans.org. Well, the COVID-19 crisis has unlocked the potential of virtual healthcare technologies. It's working well for many patients and providers, but it's presenting some difficulties as well. In our interactive session today, discussion with our speaker, Dr. Pardeep Shori, we'll discuss what's working, disclose what isn't, and share his perspectives on the long-term impact of virtual healthcare delivery. Dr. Pardeep Shori, he's a friend, a student, he's a pioneer in virtual healthcare and is currently an active healthcare provider. Dr. Shori is a family medicine physician who serves as a medical director in post-acute management. He's also a regional physician consultant for a national retail pharmacy. So thanks for joining us today, Pardeep. It's good to be with you on a virtual environment today.
Great, thank you everybody. Thank you, Dr. Kaiser. Appreciate being here and look forward to having an enlightful conversation.
All right, well, our goal today is to first outline a scope of discussion topics that'll help define virtual health, and then engage with questions from you guys, our audience. So we're starting to use the word virtual healthcare as an upgrade from the word telemedicine or telehealth. Only that virtual healthcare seems to be a little bit more inclusive today. And maybe we should even go further with the lexicon to just call it virtual care in the future. So let's start here with some questions with Pardeep. So Pardeep, let's start with a brief history and understanding of traditional telehealth as it was being used and adopted in the United States prior to this COVID-19 pandemic.
Definitely. So, if you look back, I mean, even now, telehealth can be a very diversified set of ways to engage a member, a patient, or consumer for medical needs. You can see your doctor, your primary care doctor, talk to you over the phone on a late night because you need a refill, or you have a cough and a cold, it's the weekend. So these were modalities, meaning a telephone interaction that was already there before, unfortunately, this pandemic. What happened is in the last 5 to 10 years, state medical boards, CMS, a lot of health organizations as well as associations needed to kind of shore up what is telehealth. Telehealth can be either through phone. Sometimes it can be even considered that through a video, a real-time audio video like that we have here with Zoom. Some could be just a remote patient monitoring, means you have a device, it sends you data in real time, and then maybe you pick up a phone and you speak with the patient. So because of that wide variety, that's why using the lexicon, as you mentioned, virtual health, encompass all those different modalities. And the great thing is, over the last several years, state medical boards, as well as payer groups and other stakeholders, felt there is value to both bidirection, to that of the hospital, medical front, as well as the patient, consumer, or member. And now I'm pleased to say that most states, pretty much all states, have some form of legislation or description as to what is telehealth. And now, because of, unfortunately, with this pandemic, that accessibility, that permissibility, and that buy-in from both the consumer, patient, member, as well as the medical groups have now allowed us to be able to utilize virtual health to some extent.
Well, I've heard you refer to virtual healthcare as a game changer. This morning I was watching CNBC and I heard Eric Schmidt. He's the former CEO of Google, and he said, wow, this is a game changer. With this current pandemic, it's really accelerated the adoption of virtual health. What's really happened to make this adoption, rapidly increase like it has?
I think one of the things is if you, and the analogy I would say is look at it as a triangle. So on one part of the triangle, you have is permissibility. So you had CMS, you had state medical boards, you had healthcare organizations who said, you know what, we need to improve the compliance, the reliability, the access for telehealth. They even expanded to not just simply being through video, but through phone. The other is, again, accessibility. You now have members, patients, consumers who could use their smartphone, could use the regular phone, or be able to use the computer with the video to interact. And the third one, and this is a very critical, is that, as I mentioned, telehealth has already been there. This is not something new. There's been different iterations of it, but one of the key things is having physicians, providers, those in the medical institute, to be able to deploy, utilize, and engage members through virtual health means, and to be able to get compensated for that. So when you have all those three coming together, you have a really good panacea of where now the sky's the limit. And it is a game changer because you can utilize virtual health in any shape or form as needed to get the member the best optimal care that they can get.
Well, for the sake of our audience, let's review some of the various modalities of virtual care. This might broaden the landscape a little bit, and perhaps you can expand a bit on, at a high level at least, on each of these modalities. I've identified 4 of these modalities that you might be familiar with, so I'll kind of go through all 4 of these, and then we can go back and go deeper, or you can stay at a higher level, whatever you prefer. But the first modality that I see is it's live. It's a 2-way, real-time interaction with the patient, or maybe a caregiver, or maybe the provider included with that. And so being live is certainly things that, I'd be familiar with if I was using, virtual health with a doctor or a caregiver. But extending that a little bit further, sharing from a primary care physician like yourself to a specialist, as a referral or specialty care. I may not be directly involved with the patient, but that would be really, really interesting to see that modality as well, going beyond just the patient and the doctor. And the third modality, yes.
Good.
The third modality is remote patient monitoring. Once you're released to home or maybe to a care facility. And then the last modality, I can see virtual health really working in general education, promoting healthy behavior, or even public alerts and updates and things like that. So what are your thoughts on those different modalities, Pardeep?
And if this was a multiple choice where you can say, does virtual health have either or of these options? And the answer would be all the above. And that's the beauty. That's why we use the term virtual health, because each one of those examples or different iterations of virtual health, we're actually seeing this right now in real time. We're seeing it being deployed. I can give you a kind of an example. You may have a patient who's diabetic, who's concerned about having exposure to COVID-19. They may be able to connect with their provider, and that provider may have identified them as a high risk because they have data based upon their previous visits, based upon their outcomes, how they're doing on their meds. Maybe they haven't refilled their meds, so that may be an opportunity to engage, be proactive, engage that member, and say, you know what, you haven't refilled your meds, and since we're talking about it, what is your concern about COVID? Go through a screening process. Maybe have a coordinated access to getting testing, and then bring that back to full circle, in which maybe the member comes back to the doctor's office or the provider's office for a physical exam. And in that opportunity, you may have an education opportunity where to empower that patient on what are the diet accessibility, what are things to do to better control your diabetes through diet, maybe exercise, and maybe have a Zoom meeting where you have everybody confidential, but they're able to hear a guest speaker in nutrition. So you can imagine all the different permutations that virtual healthcare can deploy using telehealth.
Thanks for the comment on all that, Pardeep. I'm going to break all the interview rules here, and I'm going to throw a group of questions all at once. And going deeper on the topic of the real-time interaction with patients. So how should it be used? There's a lot of questions. Is there a certain limited use that you should expect? What's the standard of care? What's recorded? Who sees what data? I mean, there's a lot of things there that I'd be a little bit, concerned about.
Yeah, and it goes back to the basic tenet of healthcare, in medicine. First, do no harm. So as you alluded to, standard of care. For those in the audience, standard of care is basically, I'll give the best example, is if a patient is having severe chest pain, shortness of breath, and to a lay person, it sounds and looks and hears like that they're having a heart attack or heart-related issues. The standard of care would be, okay, you examine the patient, you be able to do any additional testing, and then make that decision from there. The substandard care would be, well, I'm just going to give you Tylenol without any physical exam, without asking further information. So medical boards look at what is the standard of care, and that's not just with telehealth or virtual health, but they look at that in any shape or form that care delivery is provided within their state parameters. Now, in terms of expansion or utilization or scope, I think this is a great opportunity for healthcare associations, local care delivery, payer groups, and even state medical boards to say, you know what, let's go ahead and let's see what are the outcomes. I see there are some questions out there, and this is what the opportunity is. We have this, let's avail it. Let's ask those critical questions. Is telehealth really, or virtual health, bending the cost curve? Is it providing the same level of care that one would get if they went to a doctor's office or a medical office? So there's a lot of questions, and I think if we were able to bring those questions and organize it in a way of an analysis to really see, yes, it's great, it's cool, it's sexy, but at the end of the day, did it really improve or did it reach the quadruple aim? Quadruple aim, for those who don't know, is the quality of care for that member, accessibility of care, the cost of care for that member, and one of the critical things is physician or provider engagement, their experience. If we can hit each one of those particulars and be able to demonstrate a value-based care, which is quality divided by cost, then I really will be very happy to say then virtual health is here to stay, and it's going to be an integral part in getting members, patients, and consumers to good health.
Yeah, we used to call that the triple aim. Now it's the quadruple aim, because we're including now the experience of the participant and the physician, everybody. So I like seeing that fourth item being added to the goal sheet there. That's really good. Well, Pardeep, you mentioned the topic of risk earlier, and how's virtual health being used to sort of stratify risk, a triage of sorts, maybe? Can you explain how that philosophy takes place?
Yeah, definitely. So you may have, and think about it, and the best analogy I would say is when you go to a doctor's office. If someone is coming in and they're having a family or caregiver help them up, obviously that person at the check-in desk is going to go ahead and engage that patient and say, look, we need to see you right now, or they're going to triage them. Those who are coming in for a routine physical, or those who just need to do lab work, or those who just have a question about a pre-existing medical issue. So if you can imagine with virtual health, or you break the subset of a real-time audio video system, you can have triage questions already built in. There are some programs that have bots or virtual question systems that have a triage or a algorithm that will ask you this question, and based upon what your answer is, it will ask you another question, and that helps to engage the member, consumer, or patient, so that when they get seen virtually through an audio real-time visit, then that provider can make a decision. Do I think I can treat you? Is the standard of care will be met by us having an engagement, making a diagnosis of treatment, or do you need to be seen? And if you do need to be seen, do you need to be seen today, tomorrow, next week? Or unfortunately, the symptoms and the medical complexity is such that you need to be seen immediately. Now, then you can imagine you can have a signal, and this actually happens right now. This is not hypothetical. This is actually in real time. We have some organizations that allow the emergency room or ER know a patient is coming in. So that way it allows that seamless process from a patient coming on who may have chest pain, that the provider says, you know what, this now requires inpatient exam. Now they don't have to go into the urgent care, wait for X number of hours. They can get streamlined, brought in, get examined, and then get back to home safely if needed. And then the beauty is all that information can be transmitted to the PCP. So then the PCP is not out of step. And that's the critical thing, is that we're going to have all these great modalities, all these technology advancements. We need to have coordinated care. We don't want to have 5 different hands going around, but the key quarterback, the PCP, has no line of sight as to what has happened for that member's engagement.
So it looks like that's a pretty effective way to handle volume. And on that topic, I think we've all been educated about flattening the curve. We understand that we want to have capacity at our hospitals. How's virtual health been used to flatten the curve? Does it provide any type of load management with hospitals and primary care offices? What's your view on that?
Yeah, so the ideal speaking is you're able to, let's just say, look at it in buckets. You're able to put into 3 buckets. Those who are very low risk, those are medium, those are high. And you can make that decision tree based upon the medical history, symptoms, the duration. And in some cases, you can add an extra layer. Where are their region? Are they in an area where it is, they don't have accessibility to urgent care or ER? That also helps as well. So a good example would be is if you have a cough and cold, it's been going on for 2 days, and you're staying at home for the last several weeks, and you do not provide any direct patient care, you don't have any risk factors for COVID exposure. So that may be a great opportunity to assuage any fear or concern. It allows that member to stay at home when they're confined in their home in comfort, able to have an engagement with the provider, and to be able to see the provider and also pull up what's their background, what's their history, and be able to have control over that documentation. So if I saw that patient and I said, you know what, you have sinusitis, I'm not concerned about COVID, guess what? You can modify this note, you can give me some recommendations if the history is not correct, and you have the right to transmit that note to your PCP, and we are not recording or having video snapshots of this discussion. It gives a lot of reassurance. It also allows those patients who are at high risk, who may have significant medical issues like diabetes, hypertension, COPD, in which, again, the healthcare system may already know they're at high risk because they look at their medication adherence, are they at goal? And they may have already said, we're letting you know, if you ever have a concern for COVID exposure, let's go ahead and let's talk. Let's not wait. Let's not be reactive. Let's be proactive. And that's a great way to, again, assuage any fear or concerns or any apprehension for that patient demographic to say, well, I don't feel like going to the hospital because I'm concerned more about COVID exposure. But what do I do?
I'm willing to bet that most of the people on this event today have not been to a primary care doctor recently. You know, there's a lot of talk about primary care doctors, and there's a lot of concern because they're not seeing, you know, patients under these conditions. And talk about changing your mindset. You know, why do you want to go sit, you know, have an experience of sitting in a waiting room and all these other things that might be barriers to going to see a primary care doctor at any time? But the model for these primary care docs are, they get paid. It's been a fee for service concept. And the more they see, the more patients you see, the more money they make, right? So how do we get primary care doctors to adopt this concept of virtual health? You know, doesn't this conflict with the fee for service concept that's been around for so many years? And can they attract the consumer? Can they expand their reach? Can they reduce their cost? Can they increase their access? You know, will this work better if all the primary things that they do, their whole global, would work better in a capitation model instead of a fee for service? So you work with these primary care doctors all the time. What's their future look like here, Pardeep?
Yeah, and you know, the great thing is we've had already models in place. A lot of you may have heard ACO, accountable care organizations. There's also different iterations like bundle payments. What happens when the patient gets discharged? Do we keep track, surveillance? Do we make sure they don't get readmitted back to the hospital within 30, 60, 90 days? The other is we have patient-centered medical home, or in Medicare Advantage, they have value-based programs. All of those basically are entailing is let's empower the medical home, the PCP. Let's give them the data. Let's not burden them with unnecessary paperwork, but also incentivize them. And maybe knowing how their patients are doing, their outcomes, also incentivizing them that if they do get them to their outcomes, that they get additional, we would call it cost sharing or savings. Now, one of the things is, as I brought up in the beginning, is how virtual health can really expand is when you have that triangle achieved. And that is if CMS, if the medical boards allow for that permissibility, which means any and all patients can utilize telehealth through all different modalities, phone, video, or if you're using electronic devices for remote patient monitoring, you have the accessibility there. So it doesn't matter if you're in a very highly dense population or in a rural area. And then you have the providers are incentivized. It can be extrinsic, intrinsic motivation. It could be, well, I have 50 patients. I would like to see them all. Some I don't need to see them in the office. Some I can schedule through a virtual visit. And to be able to focus more on seeing them and spending the time, rather the virtual visit is the payment is so minuscule, it's not worth their time and energy to put in money for the technology devices and someone operating it. And the other aspect is, remember, this is a consumer world. You notice, all of you have noticed, I use the term interchangeably patient member, consumer. I can treat them as a patient, but if I don't respect them as a consumer, I don't respect them as a member because they have benefits, and I don't look at that in that, if I look in a very opaque lens, what does that do? It discourages members or patients or consumers. So if I know that they're able to utilize telehealth and they're able to get a good outcome and they're satisfied, then what's going to happen? More adherence. That's what medicine is about. I have to build a rapport with that member. I need to have them buy in to whatever I give them, whatever I advise them. If we can do that, then definitely virtual health is here to stay.
Very good. If you hear some noise in the background, of all days, they decided to wash windows at the university here. And so somebody's out here with a window washer and a lift. So I can't stop them, but I'll let you know at least I'm safe here, no problem. There have been limitations on virtual health. And a lot of these limitations, restricted what you could do with it. And these have been waived due to COVID-19. Just like a lot of the drug experiments and things, you get emergency use authorization to go by and do things quicker and better. And so obviously there is some reasons to waive some of these limitations. Maybe you can talk about some of these limitations and what's the likelihood that they'll stay in place going forward?
Yeah, definitely. So if you go back to several years ago, as I was mentioning at the top of the hour, telehealth had so many different meanings, and who can interact with it, who are the participants, who are the stakeholders, what type of modality or technology can you deploy. So one of the key aspects that CMS had looked at was the patient population had to be from a certain region. Who had to participate? So you must have someone who's a presenter, someone who's a medical professional. You must have that patient have a real-time audio video. And then who's on the other end? Can it be a physician? Can it be a nurse? Can it be a nurse practitioner, advanced practitioner? And then what can you treat? So it wasn't just, well, I can treat anything and everything. No, there may have been some reimbursement rates based upon certain medical illnesses like kidney disease. Now, since you have that triangle has been achieved, the sky is the limit, okay? And now the question would be is, where do we go from here? So if you go to CMS or HHS, one of the things they said very clearly is we're not going to tell those who are providing telehealth or virtual health that you must use X, Y, and Z device, or you must deploy purely real-time audio video. They gave that open, because one of the practices is that you usually have when you use any type of technology modality, if you use a vendor, you have a business associate agreement. And that is something that comes from OIG, and that's to make sure that the HIPAA privacy data compliance is inset. If you go to HHS, CMS, they said very clearly, we're going to, I don't want to paraphrase, but they said, we're not going to hold you to exact letter of the law. They were a little bit wishy-washy, and I don't want to go into the territory of me being an attorney, but it's one of the things that they did try to expand the scope of service. Because again, we're in a pandemic. If a provider like myself want to engage a patient, and I make sure my background, there's no one in the background, I'm explaining to the patient, here are your rights, here's how I'm going to hold the data, who am I going to share with the data, and I'm very clear and forthright, and I give them the risk of benefits, then that would be under good faith. But as we move forward, that may be something that CMS, HHS may have to look at is, okay, great, we've looked at all this, now we want to make sure we have guardrails, actual guardrails. Maybe we're going to ask everybody how to BAA as a bonafide, you must have that before doing telehealth. The other aspect, if you want to say if this is going to be a permanent fixture in the healthcare delivery system, is Congressional Budget Office, CDO, and look at the utilization of telehealth. One of the key things they were worried about is you see me, and I go ahead and I still see you in the office. What was the purpose of that telehealth visit? That already increased utilization, which means we are paying for a telehealth visit that didn't change the outcome. So that was one of the concerns that the Congressional Budget Office, CBO, sorry, had looked at. The other aspect is we look at quadruple aim. Are we achieving all those particular tenets? And also, can we deploy telehealth in any of our pre-existing value-based cares, as we alluded to, ACOs, bundle payments, primary care medical homes? I think this is going to be one of those where, just like we say, the data has to be the ruler of the day. Science has to be the hero of the day. We're going to have to look at the analytics and say, did the patient have a better outcome? Did we achieve high yield in the quality of care? And again, we have to make sure, did the consumer, member, patient, and that provider have a good outcome? Are they pleased? Are they going to utilize it? And if we can achieve all of those, then definitely virtual health is going to be a permanent fixture in the healthcare landscape.
So what about some of these boundary conditions? I would like to think I could set up shop here in Dallas, Texas, in the middle of the country, and I could practice medicine with virtual health all across the United States. Are there state limitations? Where do you see, how's that being managed? There are restrictions before, right? Are those gone, and will they stay gone, or what's the future of that?
Yeah, so actually about close to 10 years ago, each state medical board had their definition, or they didn't even have on the books, what is the definition of telehealth? Some had a term called e-visit, some said electronic transmission. So we had to kind of shore up what is the definition. So there were a lot of stakeholders who got together and said, okay, let's confine what is the definition. And then let's go ahead and let's take this to all the state medical boards. So there is a group called the Federation State Medical Board. It's a consortium of all the medical boards. And they were very instrumental because they were able to hone down what is the definition of telehealth, who are the players, what is the modality, what's the scope of service, and key thing, as you alluded, who has jurisdiction? So if I'm in New York, you're in California, I treat you, and there is a deleterious outcome. Who has jurisdiction? Is it California? Is it New York? Is it both? So they kind of put those guardrails in that you have to have a state license in which where the member is at. Now, in this situation of the pandemic, there's been more laxity on getting licensures. There's reciprocity, which means if you have a state license in one state, a nearby state will recognize it and grant you. There's an all-compact license, which means if you have a license in one state, all other surrounding states, or even those that are on the other side of the country, will recognize that license and go ahead and grant you. Now, the key is, as I brought up, standard of care. Where's the member at? Where's the patient at? Or the provider at? And then if there is a substandard care, if there is a poor outcome, if there is a complaint, who has the jurisdiction to oversee that? And if so, what are the ramifications? Because you can imagine everybody's doing telehealth, everybody's doing virtual health, and now you have, unfortunately, a certain case of providers who are treating patients and there is a poor outcome. Does that impact the overall landscape of deploying virtual health? It could be.
You know, there's a lot of insights right now on what patients want, what people want. I was down at a CVS Health Hub down in Houston, amazing environment down there. It's geared entirely different than what you would think of a typical, pharmacy store. You can take cooking lessons down there for healthy living, or yoga lessons, a lot of centered around the boomers. And then you've got the millennials out there also. And, in your opinion, with this virtual health access capability, what do you find that people really want? I mean, do they want more than what Dr. Google can give them as far as advice? What do you see the trend going on there with using this type of technology to really address their true needs and what those needs are?
I think it's trust. One key thing is trust. And I see on some of the group chats, one of the key things is who holds the data, who has access to the data, As a patient, you have the right, when you get discharged from, or not discharged, when you leave from doctor's office, you get a note or summary. You have the ability to tell your doctor or your provider, I don't agree. I don't have a penicillin allergy. Can you please correct it? So in a virtual healthcare manner, do you have the access, the portability? Who can see it? Who can't see it? Can you change it? Can you make an addendum? And then also, who's on the other side? Are you being transparent? What's the cost? If I connect, just like if I go through Amazon, I order something, I know exactly how much it's going to cost when it's going to be here. If I go on a virtual health, again, as a consumer, respecting as the consumer, price transparency, how much it's going to cost, what's the scope of service, and being transparent that, okay, we can or cannot treat that. And if we can, here's how much it's going to be. And here are who's going to be a part of this. So meaning if I see you one-off visit, then do I submit that to my PCP? Is my PCP aware of it? The other thing is, as it's brought up in some of the chat boxes, who can participate? Do you feel as a patient in the comfort of your own home, want to talk to just simply a nurse? Do you want to talk to your physician? Do you want to be able to know that the data is not being recorded? So these are a lot of questions that I think if we're going to see this as a permanent adoption, a permanent fixture, that we're going to have these questions answered thoroughly. So in order we have a buy-in from both the patient, consumer, and member, as well as the provider.
Yeah, you know, today people have a lot of questions on how to access, say, for example, testing, COVID-19 testing. And, you know, where do you go? What's the first step of the dance? How you find out where to get stuff and get plugged into this. And I'm sure that's also the case, Pardeep, when you start to talk about virtual health. I know at the university, our health plan, they did a pretty good job of educating the members about, you know, virtual health, how to access it. We had to, you know, go get an app, and then you had to get registered with the app, and then you need to know how to go about using the app and things like that. But without that coaching or without that motivation, without that direction, I would find it very difficult to know what the first step in the dance is. You know, what should I do if I want to learn more about that? So what do you see taking place out there in terms of identifying the vehicle that's used to get you up and going? How do people learn more about this? What's the process of inquiring about this? What have you seen?
Yeah, so I think it goes back to the analogy is if you don't know how to bake a cake, but you know where to go buy the ingredients, you may use YouTube to have, you know, to be able to make it, or you get with a friend, or you just simply buy it. In healthcare right now, if you ask anyone who's not in the medical field, what do you do when you have blood in the stool? For me as a physician, I already have it. I mean, this is ingrained in my cortex. I know exactly what to work up, where to go, and so forth. But if we are going to move to utilizing virtual health as a way to empower, educate, and provide the resources for that member, consumer, and patient, one of the key things you may have to have is it's a virtual assistant, or we call it in healthcare, a navigator. And this may be, again, something through a Zoom visit. It may be simply for those who are being brought into Medicare Advantage or to a physician's group that, hey, we're going to go ahead and give you the 101s on when to use telehealth. What are the guardrails? How much does it cost? That's just the same thing when you go to see a physician, or let's say, for example, if you go to retail health, a lot of them are very transparent. They tell you exactly, like a menu, this is what we can treat, this is how much it costs. So we're gonna have to be there in terms of virtual health. Be able to be transparent, how much does it cost, and education, because everybody knows how to use a phone. But if I ask you to check your blood pressure, how many people out there know how to exactly check their blood pressure? And if blood pressure is going to be a critical thing, then that's where maybe do we provide the equipment? Some healthcare organizations are already doing that for their critically ill, those who are at high risk. They already give them the device and it's all set up and ready to go. And they may have a nurse come in and show them, and they're ready to be able to utilize it. and it's seamless.
You know, we've all been pushed into using this new media technology. I kind of look at it a lot like when Uber first came out. If I ask a large group of people today, have you used Uber? They'll go, oh yeah, either I've used it or a buddy of mine used it, or I've been in an Uber vehicle. And have you used a taxi cab? No, not so much. You know, it saved me a lot of money using, you know, Uber instead of a cab. And I'm a millennial. I don't even want to own a car. I don't want to have insurance. I don't want to deal with all that. So we've been kind of pushed into adopting this technology. And I know at some point in time, this COVID-19, it's going to be mitigated. It's going to be managed. I'm confident that will happen. And, you know, but some of these significant chronic conditions that you mentioned, some of the things that are going to be with us a long time, like hypertension and diabetes, things of that nature, I'm suspicious to think that there's a way to use this virtual. People will be used to using this virtual health. And that's a really, really good place where we can start to do more and provide more along that area. What are your thoughts on that?
Yeah, I think one of the key things is it goes back at the end of the day, the triangle. If you can help the accessibility, it's ease of use, telephone, video. If it's, you know, right now everybody either uses Facebook Live or they use Zoom. So it, you know, the understanding and the adaptation is there. But then it's one of the critical aspects too is, can the provider be able to seamlessly use telehealth or virtual care in their day-to-day practice? Can we leverage the data? I mean, there's troves of data out there for those who are severely ill, those who have hypertension, diabetes. We can track who's not taking their meds. And if they're not, what's the social determinants of health? Is it a cost issue? Is it accessibility? Can telehealth be used to be a bridge, you know, bridge that gap? And one of the analogies I'll just give you is, this is something unfortunate in social determinants of health and how virtual health can mitigate that, is when you have those who have severe medical issues. We have seen they can go to the ER and it may be 5 miles away. And the reason why they go to the ER may be because the bus service is a lot easier and cheaper to go to the ER. But their PCP is 2 miles on the other direction. So there's no bus service. Uber costs too much, Lyft may cost too much. There may not be programs, you know, public health programs. So you can see already the incentivization for that patient, member, consumer is, I don't have the opportunity, the luxury for transportation. This is the easiest way. I can go to an ER, they will handle it. But we all know that's fragmentation of care. So that's one thing about virtual health. Is it worth to spend, I'm going to just use a number, $200, and give those who are at high risk, those who are the 10% that contribute to, unfortunately, 80% of the cost, and that's not their fault. It's just unfortunately due to social determinants of health. Give them the device. Have check-ins, already pre-existing check-ins. Hey, I know you're looking great. I'm going to check in on you. Don't we do that with neighbors? Hey, I know how you're doing. It's Friday. How are you feeling? Let's do that. And if the providers are able to get incentivized, either like you said, it's a capitated rate or it's a cost sharing program, then what does it do? It's a win-win, because you don't have to be a PhD in economics to know the cost of going to an ER for simple sinus infection in those who are diabetic is going to be a lot more expensive than someone who's being seen through a virtual visit.
Very good. Well, I see we have some questions from the audience, so I'm going to direct some of these questions here. Chandra, she says, are you restricting scope to virtual care for primary or ongoing care only, or would you consider including telecritical care as part of the scope now or in the future?
No, definitely. I would just say there's no restriction. We shouldn't. We know that telepsychiatry, we know that teleneurology is already there. There's a lot of evidence to support it. One critical question you brought up, and this is going to be something as we go on, is who can be on the other end? Can I have a nurse be able to engage a patient for simple diabetes management? We're not talking a nurse educating them about how much increase in medication, unless it's instructed by a doctor, but talking to them about how they're feeling, Are they having issues taking their meds? What symptoms they're having? And if there is any issues, get them plugged in to be seen by the doctor in person or virtually. So that's going to be one of the key things as well. In terms of restrictions, I think one thing is, and I know I've seen this, is elective surgeries. If you're going to do a review of a patient who is very critical, and when I say critical, means they have significant comorbid conditions, and there's a discussion if they need an elective procedure. Let's say they have a spine need, they need to have some corrective surgery, and it's elective. It's a good opportunity to use virtual health to keep track. How are they doing? Because you don't want to have that gap of 21 days that this patient says, I didn't hear from you, I didn't know what to do, I just went to the ER. Because that's what we see, right? If a patient is unsure of what to do, what do? They go to the ER. So we want to make sure we can mitigate and reduce unnecessary visits.
Okay, Chandra, you're on. You can unmute if you like. Your next question here was, do you see this uptake increasing because there's less elective surgeries and procedures taking place?
Yeah, really the question is related to, providers were not adopting this easily. And now in last 1 month, I mean, to give you our example, we were a 10-person company. In last 2 months, we have become 55 people, and I'm still working 18-hour days. The reason is that every provider wants to use it. Why? One of the motivations is the elective surgeries has gone down. Everything was stopped. A lot of these providers get paid based on number of procedures they do. And now what they are doing is they are starting up their telehealth practice so that at least there is revenue from virtual visits. It's not as much as doing, say, a colonoscopy or endoscopy, but a patient who has stomach ache, they can service their pain remotely by giving them dietary guidance and medical guidance. And even if it is off the counter medication or it is prescription medication, they are able to do that. So we have seen that sudden uptake happening in the last one. So it seems to be driven by financial reasons rather than care reasons.
Right, and I'll just bring that back to the triangle. So what you're pointing out is one of the parts of the triangle, which is utilization or billing. So I'll give you an example. If you're a orthopedic and you are treating patients for knee injuries and you've already done the surgery, now the question is, you want to prevent them from being readmitted. And 10 days from the time they get discharged to being seen in your office is a long period of time. In medical, we cringe, we freak out, for a better lack of a term, because there's so many things that can happen. So can you imagine if there's an incentivization for that orthopedic doctor to be able to do a telehealth visit in between day 0 to day 10, to keep them tracked, to answer their questions, maybe have a nurse who may go into their house, see them, and be able to transmit or do a virtual visit if a physical exam is warranted. And we actually have programs like that. That's called bundle payments, where healthcare entities, hospital entities, home health entities see that these patients are at high risk. Let's keep them out of the hospital. Now, as you brought up, in this day of age where if a patient needs to have a knee surgery, but it's considered an elective procedure, what do? Well, they're scared to come to the office. Transportation may be an issue. So what do? This is an opportunity for a telehealth visit. You may have, for those patients, deploy a house call. There are some insurance groups actually have called house calls, and they're built in specifically for those patients who are at high risk. So this is going to be something that needs to be ironed out, needs to be granular. And you've got to have buy-in, like you alluded to. If the construct of healthcare is the more visits I do or more procedures I do, I get paid, then we're going to have a different format, a value-based format. That's what Dr. Kaiser alluded to, a capitated system or a value-based program or a bundle payment. Because at the end of the day, like you alluded to, if that provider, in this case a specialist, is they're their business model is predicated on doing procedures and they can't do it, telehealth is not going to quote unquote pay the bills. And we see that right now with dental. Dental is having a major issue because they don't have the ability. How can you treat someone with a cavity abscess? You cannot keep giving them antibiotics day in and day out. You've got to see them and do a procedure.
Yeah.
So we have another question here from Devansh. How would virtual care affect the scope of practice for nurse practitioners and physician assistants? What would be the hierarchical system for non-emergent cases?
So if you look at a lot of the vendor groups out there, even some healthcare systems, they may say, okay, for routine checkups through a virtual visit, let's say diabetic hypertensive, they may want to have that with their physician, an MDDO. If it's something of an urgent care need or same day need, that's where you can deploy a nurse practitioner or PA. Again, what's one of the key things is permissibility. So, and again, the triangle, permissibility. Who gets to participate? What's their scope of service? So a lot of states already have that nurse practitioner PAs, or what we call advanced practitioners, can operate with autonomy. And when I say that means they don't need a physician to oversee them or to do some relegated responsibilities of reviewing charts. So that's one thing is you may deploy a mixture or a hybrid or a blended system where you may use nurses for certain aspects of virtual health. You may use nurse practitioner PAs, advanced practitioners, and then those who are maybe very critical, maybe telepsychiatry or those who are teleneurology, you may have to have someone who's an MDDO.
Okay, I've got a combo question here. It's kind of insurance and employer related. So how's the insurance industry responding to billing on virtual health, and large employers self-pay? Are they taking a position?
So one of the things is actually before this pandemic occurred, actually at the infancy of telehealth being expanded across the states, one of the things we saw was self-funded employer groups. So these are those who say, you know what, we will take on the delegated costs, the full burden, total costs of healthcare, but we need someone to help manage it. So they call it third-party administrator, TPA. So if I am X, Y, and Z business, I utilize a payer group to help manage the claims. So this is a great opportunity. It's a low-hanging fruit. I have patients or I have employees who have to take time off. They have to go trek on the other side of the world, or in this case, on the other side of the city, because they're highly dense populated, to get treated for a cough and cold. Is there an ROI of having an on-site employee help? Or for just the low-hanging fruit of cough, cold, is telehealth a good viable solution? It helps improve truancy. It helps for those patients, or in this case, employees, to feel good that, hey, I'm working in this company. Now, fast forward to now. A lot of payer groups have already said, we're going to allow for telehealth. We may waive the copay. One thing we're seeing, and there's been some reports, is some of these self-funded groups or self-funded employers are saying, well, we're going to have the patient, or in this case, the employee, pay on the front end, and then we may reimburse on the back end. Okay. Those are the things that's going to have to be worked out.
We're getting close to out of time, not out of time yet, but getting close to the top of the hour. A couple more questions here that you can give quick answers on, Pardeep. A follow-up question from Chandra. Can a bedside nurse consulting an intensivist be brought into the fold as well? Do you see the role of wearables playing a major role in that same activity?
Yeah, definitely. And, and I'm going to kind of do a trifecta, if you want to call it. I see the other question, and I'm going to give you an example. Let's say, suppose you have a patient who had a valvular heart replacement, okay? They didn't need to go to a SNF or a nursing home to get care and then go back home. Now, for those, when you have any heart procedures, sometimes you're on blood thinners. And I have already said, physicians freak out when it's 0 to 10 days. That's just too long of a time to know what's going on with the patient. So imagine a nurse goes to see that patient, goes ahead and examines them, does a blood test to see is their blood thinner medication in control, maybe relays that information to a scheduled visit to a PCP. Now, let's say in that period of time, it's after hours, because, you know, unfortunate things happen during after hours. And now they know there is a CVS Retail Health nearby. The CVS Retail Health, and some of them are going to start doing this, will already know this patient is high risk. And they may be able to say, hey, if you ever have any issues, please come and see us if you can't see our doctor. So you can imagine this myad structure of utilizing telehealth, utilizing home-based care, and having an actual brick and mortar facility if something really requires someone to be seen in person when it's outside of the, or it's during the after hours of their primary care doctor, or in this case, a specialist.
Okay, last question here before we wrap up, and this is for James Ramsey. What about blood samples, getting patients? How can we factor that into telehealth? Would decentralization of getting the sample from, say, someone like a local CVS clinic be an option?
So Dr. Kaiser brought up is that, you know, there are health hubs, and one of the strategies is you're not only just to get your blood work done, but you get educated about your benefits, about healthy lifestyle changes. You can utilize telehealth as a way that if you have a diabetic whose blood sugars are high, they can't get their med refills, but they're concerned about going to see their PCP. If they know that they can go ahead and get their med refills, review their meds, come in and get blood tested, and then be able to follow up with a nurse or their PCP on the results. That could be a great ideal situation because you reduce their risk of unnecessary exposure going to the ER, the cost component, and then having that collaboration between a CVS and their PCP. And then you have lab work that's in there because, again, we want to have as much touch points on the patient's trajectory in their healthcare, you know, in the whole ecosystem.
Well, we are out of time, so I want to thank Dr. Shori. Pardeep, thanks for sharing your expertise today in this topic that we've been covering. And the Health Tech Forum, it's working on our next presentation, so look for information on the Tech Titans event calendar on the Health Tech webpage on the website. And on behalf of the Tech Titans Tech Forum, thanks to everybody for participating here today. So we are officially adjourned, and welcome back next time.
All right. Thank you, everybody. Be safe.